Hi, everyone. I'm Michael Ostacher. I'm the digital content editor for Evidence-Based Mental Health. Thank you for joining us. Today, we'll be discussing a terrific review paper by one of our guests today, Carmine Pariante and Louisa Tomaleri. Increased attention should be paid to perinatal mental health and to the need of dedicated services. It's an extremely important topic. We have several guests with us today. We have Professor Pariante himself. He's a professor of biological psychiatry at the Institute of Psychiatry at King's College London and consultant perinatal psychiatrist. His work specializes in the role of stress and the pathogenesis of mental disorders in response to psychotropic drugs, and focuses on depression and fatigue, particularly with respect to the perinatal period. We're also lucky to be joined by Simone Vigod, who's currently the Shirley A. Brown Memorial Chair in Women's Mental Health Research at Women's College Hospital in collaboration for the Center for Addiction and Mental Health at the University of Toronto, where she's Associate Professor of Psychiatry. We're really glad to have them join us. We're also joined by Andrea Cipriani, who's the editor-in-chief of Evidence-Based Mental Health. So to get this hangout started, Carmine, why don't you review your paper a bit and let us know a bit about the background, and we can start a kind of free-flowing discussion, I think, about this important topic.
Of course. So Louisa and I were interested in kind of looking at the most recent studies on the potential negative consequences of antidepressant use during pregnancy. I've always been interested, both as an academic and as a clinician, in the treatment of perinatal mental health problems, and in particular in the use of antidepressants. And I think the conclusion from what is certainly just an opinion piece and a citation of selected papers, especially the most recent one, is that as clinicians, we're still struggling with the evidence, because, of course, none of the studies that have been investigating the effect of antidepressant in pregnancy are clinical trials, and is virtually impossible to disentangle the negative consequence of depression in pregnancy versus the negative consequences of antidepressant use during pregnancy. Most of the data, most of the research in this field over the last kind of 10 years or so have been on cardiac malformation and pulmonary hypertension in the baby. So these are largely, of course, medical conditions. And all of those studies found that if there is an increased risk associated with SSRIs in pregnancy, it's very small, and it disappears once we adjust for all the potential consequences of depression in pregnancy. So the fact that these women may be using more off-label medication, they may be smoking more, using alcohol more, being less careful with antenatal care, less engaged with services, and so on. And the same objection applies to the studies that we discuss more at length in this commentary, which are the most recent studies testing the potential association between SSRIs used in pregnancy and the risk of autism. Now, the issue of autism is interesting because, of course, there is a theoretical models for which increasing serotonergic neurotransmission in the fetus during brain development could potentially change brain function long-term, and we know the serotonin has been implicated in autism. So the biological model, if you like, is interesting and plausible, but nevertheless, those studies again fail to find a clear answer, just simply because they cannot disentangle the effect of depression, so the indication to treatment versus the effect of treatment. In fact, one of the studies found that exposure to antidepressant before pregnancy, which is a clear manifestation, if you like, of the psychiatric vulnerability of the mother rather than any direct effect during pregnancy. Exposure to antidepressant before pregnancy was enough to increase the risk of autism. And so in this context of course, we also need to remember that untreated depression also has profound consequences on the long-term physical and mental health of the children. Not talking, of course, of the mental health of the mother, because, of course, untreated depression in pregnancy predispose the mothers to postnatal depression, and so to a kind of disruption in mother-infant interaction that can go on for weeks or months in the postnatal period. But only if we just look at the data on children. We now know, both for our own research and from larger studies conducted in the ASPAC cohort, the exposure to depression in pregnancy is associated with an increased risk of depression in the offspring when the offspring reach adolescence and young adulthood. And we also know that, of course, depression in pregnancy is associated with shorter gestational age, smaller weight at birth. So, you know, there's a number of large complications and long-term consequences of depression in pregnancy. There's a large amount of evidence from animal studies where chronic models of stress during pregnancy disrupt long-term mother-infant maternal behavior and also have profound effect on the baby's stress response and behavioral and brain function. So I guess we're concluding by saying there's enough evidence that depression in pregnancy can be really disruptive for the long-term effect on the children, and as such, that of course should be weighted against the potential risk with SSRIs, and the final decision has to be taken as part of an informed discussion with the mothers. Nevertheless, of course, for the most severe case of depression, where there's a clear clinical indication that even with having a higher threshold for treatment, we will still consider that the best option. And certainly as a clinician and a clinical psychiatrist that works in the perinatal psychiatry services, this would be the clinical practice that we advocate and we use in our clinical day. So consider antidepressant treatment in the cases that obviously have a high level of severity of depression, that justify the potential risk, and discuss this with the mother.
Simone, if you unmute, would you care to comment, or we can just start a discussion as it is? Obviously, there are multiple levels on which we could discuss this. But do you have some first comments that you'd like to make?
Sure. So I'm a psychiatrist, and I run a specialized reproductive mental health clinic in Toronto, Ontario, where we see a large number of women who are preconception and making decisions about whether or not to continue antidepressant medication in pregnancy, as well as women in early pregnancy who are making decisions about whether or not to stop. And I think one of the first things I would point out, I think that we just heard the state of the literature in the field, and I'm in agreement with the vast majority of most of what was said. But I think one of the things that we found when we did a clinical study, one of the things that we found when we did a clinical study in our group was the very high level of decision-making difficulty as measured through the concept of decisional conflict that women experience around this decision. And so they really feel, and we also had some qualitative data around it, women really feel like they are being put in between a rock and a hard place. Mm-hmm. And a lot of and what that creates is a lot of distress. And of course, high decisional conflict also, it delays people making decisions. So in this case, that would look like people maybe not making a decision at all, so going untreated, or it can lead people to make potentially less effective decisions. So for example, being afraid to go in where you might even be able to receive psychological treatment because out of fear an antidepressant might be discussed, or in a more serious case, self-medicating with something else instead of antidepressant medication. And I think, what also another piece of research related to that we've done is also about, a lot of the studies, and you can see headlines in the media that will say things like 86% increased risk of autism in children exposed to antidepressants, right? Well, an 86% increased risk, that's like I guess a relative risk, let's say, or an odds ratio of 1.86, right? So if you don't think about what the absolute risk is, that could be going from, a 1 in 1,000 risk of something to less than a 2 in 1,000 risk of something, right? And so I think, I think on some level, while there is importance in disentangling the impact of depression in pregnancy or untreated depression or anxiety in pregnancy and the drugs, I think it is important also to take a step back and say, okay, so do we, even though we probably will not be able to sort this out with, observational data, when we're seeing for most outcomes a relative risk of less than 2, and this idea that there are so many factors we cannot account for, including with the autism issue, the genetics of autism, depression, anxiety, severe mental illnesses are all interconnected. So someone who has a more severe disorder may simply by virtue of genetics be more likely to have a child who has another one of those disorders. And if women are only using medications when they have more severe disorders, that's very difficult to disentangle. Some of the twin studies, I'm pretty sure almost all of the twin studies around autism have had a null result when there's been one exposed child and one unexposed child, although most of them are underpowered. So, when we're thinking about this more broadly, we're talking about if there are even increased risks associated with these medications, they're small to non-existent. They have to be weighed against the impact of untreated depression, not just in pregnancy, but over the long term. The longer you leave a mother untreated, the more chance she will have postnatal depression, chronic maternal depression, and that we know very, very clearly has substantial effects on the children. And I think, I know we're here to talk about exactly what the evidence is, but I think the evidence also supports that women are very distressed about this, that they're probably not, it's such a confusing, there's so many confusing messages that I'm not sure that we're doing our women and even doing like the primary care providers who do most of the frontline management of antidepressant use in pregnancy. I'm not sure we're doing any of them a really good service by quibbling too much over this, and that might be a controversial thing to say. So let's open it to that.
I think that's actually terrific. I'm looking at, I'm writing a guideline summary for a different topic for JAMA, synopsis, and they really want people to be able to examine the absolute risk of things rather than the relative risk of things. And that when physicians talk to each other, they often use relative risk to talk about what the chances are of something. But when you're examining treatments, absolute risk is much, much more helpful, I think, to both patients in terms of understanding what the real risk is, and probably to us as clinicians. And so I think you're mentioning that is really quite pertinent. One of the things that Carmine brought up, which I think is really important, is that we don't do randomized trials of these things, right? And a lot of these things are really about population effects. And so, how do you, with the women who are lucky enough to get into your clinic, especially the ones who have the foresight to make decisions before, and how do you engage them in a discussion about the information?
So I guess that's a question for me. I mean, I think I always start with women and talk about the fact that, of course, in pregnancy, there's an instinct always to focus on safety. And I always remind women and their partners and their family and other family members who they want to bring into the conversation that the first thing we need to talk about is the indication for treatment in the first place. And so I always start out with what are the risks for you, for your family, for your other children, and for this baby of not treating or of incompletely treating your illness. And I want to be clear that, I think the vast majority of us are focused on psychological treatments being the first line treatment for depression and anxiety in women of reproductive age, and women, certainly women who are pregnant. And so that's a whole nother kettle of fish about how do we ensure appropriate access to high quality evidence-based treatment so that we are not using pharmacological treatments just simply because we can't get people the care that they need. So that's a whole other issue. But when we have a woman whose illness is severe enough that she probably requires antidepressant medication treatment either to stay well or to completely treat her illness. I mean, that's the context in which we're talking about this. But really focusing on really trying to balance things out in terms of, what are the risks of no treatment? What are the risks of delaying treatment? And then let's talk about what are the potential benefits and risks of using a pharmacological treatment. And one of the things that we do in our clinic explicitly, and also we've designed an online patient decision aid to help women with these decisions, which we did a pilot trial, and we've actually just launched our cross Canada trial. So we really worked hard in the decision-making literature to talk about this absolute risk issue and to talk about having a common denominator when you talk about things, right? So if we, for example, if we talk about a woman whose depression is untreated in pregnancy, out of 1,000 women, probably close to 700 of them are still going to have depression postpartum, right? When we're talking about the risk of, for example, a cardiac malformation in women who don't take antidepressants, that risk is probably going to be 5 out of 1,000. And, maybe if the increased risk is even true, it's not going to be more than 8 out of 1,000 if you're exposed to antidepressants. And so putting everything with a common denominator in absolute risk, theoretically, and we're trying to show this in our trial, should make people be able to have a better conception of what the relative benefits and risks are, and then be able to really think about what they're scared of, what their values are, and what their preferences are. But when you say to someone, well, there's a 1 in 7 risk of this and a 0.5% risk of that, that makes things extremely difficult for them. And so the other thing you can do also is to talk about, well, if there's a 1 in 1,000 risk of something bad happening, that also means there's a 999 out of 1,000 chance that actually you're going to have a good outcome. And there's lots of decision-making literature about how important it is to be able to present things in that way, because providers, patients, people don't have really good sort of numeric literacy and being able to put percentages and 1 out of this. Like, we really need, I think, in this area to be really clear and really consistent with how we give those messages. And I've often found that when women hear it in that way, they just feel less confused, and they may still choose that, a 1 in 1,000 risk is not okay for them. But, I feel more confident that they're choosing based on really hearing and really are, not because of confusion. So I hope I think that's helpful.
I mean, I also, as Simone, I also do clinical activity in perinatal psychiatry, and I share completely Simone's kind of view in the way of presenting, not only numerically, but I think also kind of emotionally, the risk of untreated depression. And I've also, I've noticed that women are actually quite, of course, they're knowledgeable, they read on the internet. And so they know about, the depression is not good for the body, and they've read about maybe stress hormones and, inflammation and so on. And so they are actually saying, well, how is depression affecting my body? Is this depression creating an environment which is not good for the baby? And so that's, there's also that kind of a level of engagement that can also help them understand why an antidepressant may be required. And sometimes as a personal level, I kind of point to them how bad it is when they are depressed. And so I'm only saying, I say to them, look, we're not talking about being upset a couple of days a week. You're coming to me and you're saying that you're crying all day, every day. I mean, how does that will make your baby feel inside you? So, I think women understand that depression, untreated depression, especially if it's moderate or severe, is really bad. And so, I think it's that kind of understanding of that there's no these are difficult decisions, but that somehow we know that depression in pregnancy will have some, will increase the risk, as Simone said, many more times than the potential risk associated with SSRIs.
Although at the same time, I'll just jump in. I think it's also, you probably would agree that it's also important to make sure that women don't feel that is in a blaming manner, right? That this is something that, that they're doing or not doing. And I think sometimes that can come out as well. So I think it's really, I think a lot of this is really about being really, really fearful that there's something like that they're doing, and women talked about sometimes doing an act of commission. Taking a drug would be better than an act of omission, but regardless, there's a whole lot of blame. And I sometimes speak to women about, unfortunately, we don't have a crystal ball, and with pregnancy and obstetrical outcomes, so if there is a negative outcome, the chances that it was due to either the depression or the antidepressant are actually fairly low. And even in the research that you read that does, when they look, there are a couple of studies that have looked at, for example, what proportion of the variance in autism outcomes would have been explained by an antidepressant, for example. That number is extremely low, right? So I think that's the other important thing to say, that when women are making a decision, really understanding if there's a negative outcome, that the chances are that it was because of one of these decisions that they made is actually pretty low.
I suppose that the decisional conflict wouldn't be very high if the perception of the stakes weren't as high as they are here, right? So it's,
yeah, and also I think there's a lot of there's also confounding elements, kind of confounding social elements and cultural elements which complicate the picture. And so, for example, people forget that the antidepressant that we all routinely prescribe are all off patent. So there's really no financial incentive for anybody to prescribe medication. Sometimes when I discuss antidepressant prescription in pregnancy, some of the objection that people bring up in kind of conferences or social media or kind of more kind of broader settings is whether this is coming from a pressure from pharma to all of us to prescribe more. And so it's also kind of reminding people that these are decisions that are all taken in good faith by a caring clinician with a patient, with a concerned patient, and there's really no other pressure coming in. And certainly, there's no financial pressure, no financial implication for anybody, because these are really medications that nobody makes any money with at the moment. So I think it's, and with this, this is just one example of other things, about the cultural element, our understanding of mental health problems, stigma against mental health problems in the society. So seeking help, how much women are not seeking help because they would feel they're afraid of being stigmatized because they are not, because they are depressed. There's a lot of pressure about, being happy in pregnancy. So also the fact of acknowledging that actually this, this dream of always being happy in pregnancy is also kind of in contrast with the message from society. So, there are multiple, in some countries, there's also a concern about possible social consequences of a diagnosis of depression, where the social services will come and take the baby away. Again, these are not, they're usually accentuated and unrealistic fears, but nevertheless, they do participate in the decision making, first in seeking help, and then when you're seeking help in kind of being honest about the symptoms and being honest about the treatment. So I just say, there's additional cultural factor that influence decision making, which are well beyond just the simple evidence, how we relay the evidence.
I would agree with that. And I think that, when someone has a mild history of illness or mild illness, or, or who has responded very quickly in the past to a medication, those are women where actually the decision probably is to try and be off a medication and see how they do. right? When someone has an extremely severe history, let's say a multiple medication trials, hospitalization, didn't respond well, though, you know, or severe suicidal ideation, those are cases where we say, well, you know, definitely it looks like the benefits of being on pharmacological treatment outweigh the risks. The problem is these women in the middle, where it's really, really hard to quantify, you know, whether, like how the risks and the benefits are going to play out. And one of the things that is very complicated that I do not think we've done well with the evidence, and I'm not sure I know the answer to this, although maybe Dr. Cipriani could weigh in about how we might think about this, is, you know, a lot of the studies that are published, they're each about one separate outcome. And so, you know, what does that mean? So then women and providers have to look at all these separate studies about separate outcomes, and we don't actually know really how they all play together, right? Are there some moderators or of treatment outcome? Like, are there some women who would have all of those negative outcomes and others who would have none? Is it evenly spread? Like, I think we need to think about how exactly we do that work. I'm not sure if I've articulated that problem clearly, but I do think that's one of the problems in the way we've thought about the evidence, that we're thinking very linearly and outcome by outcome, but we haven't put it all together. And in real life, you want to know kind of what's my overall chance of having a good outcome versus a bad outcome, not 25 different things that you need to worry about.
It's interesting what you said. I'm sorry I lost you for a moment earlier, but I think it's interesting what you say, because I don't know why I don't expect discussions like this always to lead back to behavioral economics, but they have again, and it's sort of remarkable. That I think that as a group and as a field, and I think what Carmine said is important, that we're not necessarily biased financially, I think, but as a group we are biased towards, well, we do all agree that treatment is a better idea if they're severely ill, and that the risk is probably very small. But the question really is, how do you then communicate that to the people who actually have to live with the decisions about this? Because if there's a bad outcome, the amount of guilt and shame and concern in a mother who's made that decision is going to be enormous, I think, right? And so how do you then frame to them what the decision making is, right? So as you pointed out earlier, you know, if you have a 7% risk of something, that means you have a 93% chance that it turns out the other in a positive way, right? And so how do we then frame these data, which as you rightfully pointed out, have not been consolidated to include all the possible outcomes? We do outcome by outcome, but how is it that we can communicate to people what we all feel as clinicians is probably the best medical decision for people to make in a way that makes people understand it and make a decision that conforms to that?
Well, I mean, it's, you know, I think it's a complicated question, and you probably just do it by a combination of explaining the evidence in the most objective way, and you know, kind of make sure the woman understands risk and benefit of both conditions. I mean, I think that Simone, Simone, you're definitely right that there's something different about doing something compared to not doing something. And so, you know, in a way, there's more of a responsibility of making a choice of taking an antidepressant rather than just being depression, be present. And you know, we can argue about all the moral issue and of mission versus commission, but I think that's something which plays in the mind of mothers and they participate in decision making. And I'm not sure whether how we address this, because of course, not taking medication is also a choice. And I guess we can all, you know, it's about just being clear and supportive either way.
Yeah, I mean, Andrea, Simone did ask you earlier to weigh in, and it would be helpful if you had a comment. So how can we address the question that she raised, which is that we tend to look at these things outcome by outcome, but we really need to have a composite for helping people make decisions?
Yeah, of course, this is a crucial question, and I think it's partly because of the limitation of the evidence we have, because it's also difficult or not automatic to combine all the different outcomes from different studies. And at the same time, I think it's very important to decide how to interpret this data, because the other risk is to selectively or manipulating this kind of data. The field is very tricky, but the question I have for the expert is, which is the kind of study or study design that would be ideal to help the decision-making process?
Yeah, I can.
Right, there we go. I mean, I can tell you that I really have wondered about some of the, there is a literature on study designs around how you combine benefits and risks into one outcome. Some of that work came out of Pittsburgh around antidepressant trials versus interpersonal therapy, right? And so, you know, you could imagine that you would actually have almost like a report card of different potential outcomes, and then speak to women about, you know, taken all together, what sorts of, you know, what sorts of, you know, combinations of outcomes, like almost ranking them, like what combinations of outcomes would be, you know, good to bad based on, you know, worst to best. And then you can start looking at, then you can start kind of, I guess, assigning value more to the types of outcomes. I mean, I think the problem is different people are going to value different things. So, you know, in my research program, what we ended up landing on is the creation of this patient decision aid, which what it does is it first talks about, you know, what is depression in pregnancy? Why would you want to treat it? With this idea of like, you have to understand, you know, what it is, why would you want to treat it? Then talks about all of the different treatment options and their efficacy, including pharmacological and non-pharmacological options. And then it goes into, you know, in terms of antidepressants specifically, you know, based on the data we have with all of the caveats, this is kind of the best summary of the literature that we can give using absolute risks. And then once that's happened, it says to women, you know, okay, so now let's take all this information we've given you, and which one of these matter to you? Which one of these matter to you? What matters a little? What matters a lot? And then they end up doing these interactive exercises to have a look. And then what that then allows them to do, it allows them to hone in on, okay, what is it that's really bothering me? Is it this increased risk for autism? Or is it, you know, a side effect I might be getting from the medication? And that allows them to distill it down a little bit. And then we have also a section about who else is in your decision-making sphere, right? So who's making this decision easier for you, harder for you, to really understand what the influences are on their decision-making. And then they can go back to their provider, you know, with at least some kind of a little bit more clarity about what their values are, what their preferences are, you know, with the knowledge that we do not have crystal balls, and we can't, like, we can't guarantee any outcomes, but at the very least, to try and feel more clear, if you can feel more clear about what the issues are, what your preferences are, what your values are, then maybe you can make a more comfortable decision that you feel more comfortable with. And then in the theory around decisional conflict is that if people have less decisional conflict, then they will make more timely decisions and possibly more effective decisions about their treatment, meaning that in the end, the overall outcome will be more favorable. And so that's what we're testing right now. I mean, in our pilot trial, when we tested it out with women across Canada, they had a huge reduction in decisional conflict that was much greater than the women who received the similar information but non-interactive without the interactive piece. And now we're looking to see how this influences what women decide and ultimately their outcomes. And we're going to follow women all the way out to the postpartum. So, I don't know what the answer is for helping. But I think it's very clear that we need to help because it's so distressing for women. And so part of it is, can we disentangle more and more to get more certainty? But at the same time, on some level, we have to take a breath and say, okay, if we don't have certainty, we still need to help people manage because people still need to make decisions now, even in the face of uncertainty.
Yeah, this is exactly what I meant. I think we need to take decision on a day-to-day basis and help the patient decide. And of course, having a tool is probably the best way to go forward. And I think also your idea to collect data after using this is also important for the quality of the data. But it seems to me, talking with the expert today, that a lot is about how you present the evidence rather than, because it looks like the evidence available is somehow convincing about what's out there. So of course we need to improve it, but we can use the available data to base our judgment. So in terms of how to present, how to discuss this with the patients, do you have any, both of you, do you have any advice, anything, any tips for the young psychiatrists or GPs who need to address this issue with pregnant women?
I think that I've said a lot already, but I think the other piece that I would say is to really try and hear what your patient is saying in terms of her thoughts, fears, what she's read, what pressures she's under. Because I think, as psychiatrists, as physicians, as whoever's helping people make this decision, we are, if we can be compassionate and really listen, then we will be able to help people make, the most comfortable decision that they can make in this context. I think the risk, in my opinion, is a little bit going too much, like talking over the patient, saying, well, this and this and this and this, but really trying to listen and see what they hear and see where they're at. And I could be wrong, but I think that empathy goes a long way so that people don't feel like they're so alone in the decision and they feel heard.
I agree, of course. I think one of the points, however, that we need to remember is that ultimately, as much as we want to empower patient, and there's, the relationship between patient and doctor is much more collaborative now than has ever been before. They do look at us with the hope that we can guide them. And so I think we also have to be honest sometimes and just basically say, look, I really think that the best option for you, considering, as you said, the background, the clinical history, the best option is, okay, not to take a medication. I will see you regularly and see how things are going. We can always start at a later stage. Or I really think the best option for you is to take the medication or is to continue to take the medication. And there's always a risk now with the emphasis, which is correct emphasis on collaborative relationship and on kind of shared information and consent, that ultimately we ask the patient to do our job as well. So we give them all the evidence, we kind of go with whatever they want. And I think, we also have to provide guidance and take the responsibility of saying, I really think that's the best things, but of course, respect their decision if it's not, that's what they want to do. And it's the fine balance between still bringing our expert role and fulfilling the guidance that they seek, while at the same time respecting their independence and not, put any pressure, even if we've done in good faith, one way or another, or make them feel undermined if they're not going with the course of action that we recommend. So it's a fine line as a clinician.
Well, I guarantee, I agree with you completely. I think I'm talking about being patient-centered in our care, not patient-directed necessarily, right? But I do think that it is the patient ultimately who will go to the pharmacy, who will pick up the medication, and who will take them or not. So I think that's more what I meant about really trying to hear what the fears are, because if I'm making a recommendation for a woman who has quite a severe history of illness, and I'm telling her that really in my, although I can't make any guarantees, it really seems to me that the benefits of continuing medication would outweigh the risks, I still need to hear what her fears are, so that her conflict is, I can help lower her conflict as much as possible, so that she's making an informed, driven decision. I think that's more what I meant, not that we shouldn't be offering our opinion when we have one.
Yeah, and as clinicians, as psychiatrists, do you think it's more difficult to have this kind of conversation or take this decision, as Carmine was saying, to do our job with pregnant women? Because sometimes I think with my patients, because especially if they're young women, you can predict or discuss in advance what happens if. And sometimes part of the education also for the GPs could be to start discussing these issues before, not necessarily when people are pregnant, when women are pregnant. So is it something that matters in your clinical practice?
Well, for us, I mean, I think we're more and more, preconception healthcare has traditionally focused, there are recommendations in preconception healthcare to focus on the management and optimization of conditions of chronic disease, right? But I think that the incorporation of the management of depression into the category of issues that are addressed in preconception care probably hasn't been as much as it should be. And I think there are questions about how can we help the people who are delivering preconception healthcare, because that's not always going to be the psychiatrists, right? To make, to think about how to consider the management of depression and anxiety in preconception healthcare. If we go away from depression and anxiety and we start to think about bipolar disorder and epilepsy, for example, as you know, in France, it has now become, really against guidance to prescribe valproate to any reproductive aged woman, because of the chances of, if it works for her and then she becomes pregnant, that the teratogenic potential would be large, right? So that, you could argue about whether it's okay to dictate things like that, on a policy level. But, it is kind of taking a step back and thinking about preconception care and thinking, 50% of people with mental health issues are women, women of reproductive age. That's the time of onset. So, I would argue that we probably should be thinking about pregnancy, when we're prescribing to people who aren't even thinking about becoming pregnant yet. Like we probably should be giving that some consideration, but that requires some thought about how we do our training and how we approach, how we approach the way that these things are put forward in guidelines.
I think it's really important to acknowledge that we're talking about 3 different major healthcare systems here, even on this call, right? The U.S., Canada, and the UK, and I think it's worth acknowledging that there are major issues about how to implement something like this. But I think your point is really important, Simone. That we know what we think might be best, but it's really important to try to communicate that so that women who are making these decisions can be making decisions based on their own values and choices. But sitting here in the United States, I'm thinking, oh my goodness, the proportion of people who are getting health care is not high enough, that are getting prenatal care. Somebody who respects their decision-making capacity is also not high enough. And how do we, a decision-making tool like the one that you were developing is one that could have wide use, I think, and might be able to give people the ability to make these kinds of complex decisions, whether it's in depression or bipolar disorder or other mental illnesses in which people have to make decisions like this. Wide berth.
I mean, we also have a preconception advice, and I often do the preconception clinic. And, you know, it's important to remember that sometimes we can, you know, certainly in my clinical experience, that we have women coming thinking that they cannot have children, that their mental health problems and perhaps the medication they've taken so far would make them unable to have children. So somehow the preconception advice sometimes is actually about the opposite, about reassuring them that they can, and what kind of support they may need, and what are the alternatives in terms of medication or treatment, and as Simone was saying, what could be the best plan in terms of stopping versus continuing. But you know, sometimes it's also about helping and supporting them through the pregnancy when they perhaps thought that they couldn't, or they really felt that their only choice was not to have children. So there's also that element as well.
I think that's great. Would you like to make a final comment before we close up this hangout?
I would just say it's, I appreciate being able to speak about across 3 healthcare systems about this. And I think it's really interesting that how much alignment there is here just around how complex a decision this is. And, you know, it's just that I think this really highlights how important an area this is.
Carmine, do you have a final comment?
I think, you know, in the UK, we have been within the broader problem of, you know, underfunding of the NHS, the perinatal mental health services have been supported a little bit more, perhaps probably because they have been, the services have been so unavailable in so many parts of the countries that you know, there's been an attempt to compensate for that. I think just to remember that, of course, we are discussing what's the best advice we can give to women and how. We have to remember that most women don't have access to any advice. Yes. They cannot see any specialist services that can inform on this, and so we also need to remember that there's an element of for professional that works in this area to continue the kind of formal and informal lobbying of government and organization and kind of policymakers to support this kind of services, because ultimately a lot of women cannot have any kind of advice.
No, exactly. Well, on that note, why don't we wrap this up? I want to thank everyone for joining us today on this live video hangout from Evidence-Based Mental Health. I want to thank our author, Carmine Pariante from London, and Simone Vigod from Toronto, along with Andrea Cipriani. I'm Michael Ostacher from Stanford University. Thank you for joining us. You can follow our work on Twitter at EB Mental Health, and also follow discussion about this hangout and our other hangouts using the hashtag EBMHchat. Thank you very much.